Good evening, and thank you for attending this session. I hope that it'll be educational for you and shed some new light on this emerging mechanism of action that we're going to be employing increasingly in our clinics. My name is Philip Mease. I'm a rheumatologist based in Seattle, and I'm joined this evening by two wonderful colleagues, Mease Deodhar from University of Toronto in Canada, and Atul Deodhar, who is just down the road from us in a city that's not quite as cool as Seattle, but from Portland, Oregon. So we're going to be taking a look at TYK2 inhibition. Just a couple of housekeeping items. First of all, we want to thank PeerView, which is the CME company that is hosting this session under this grant from Bristol Myers. We'd like you to complete the pre-event survey, and they're peppered throughout the presentations. There will be some further QR codes and whatnot. And throughout the program, if you could submit your questions, we'll address them during the Q&A session. You've already been instructed about the QR code, and for virtual learners, please respond to polls on your screen and enter questions in that chat window. So if you do access PeerView, you'll have access to some of the slides and practice aids that will be complementing this program. So as mentioned, our focus is going to be on teaching about the biology and role of TYK2 as and the inhibition of TYK2 in PSA is what our primary focus will be, and identifying patients with PSA for whom this therapy may be appropriate, and then talking a lot about personalized PSA management. And as you know, and have heard many times, PSA is a very heterogeneous disease with multiple clinical domains that all may present slightly differently in different patients, and so need their own individual addressing. So we know, I've already mentioned about the heterogeneous nature of this, so arthritis, enthesitis. How many of us have seen a patient present with pure enthesopathy, for example, as their presenting manifestation, or axial disease as part of their presenting manifestation? And so it can be quite different from one patient to another, and that's what I tell patients when I see them for the first time. And then we'll tell them that we're now in reach of achieving low disease activity or remission, which are targets of treatment, and I emphasize why it is that we're targeting this low disease activity state, not only for their own comfort and prevention of joint damage, for example, but also some of the other comorbidities that may accompany the condition, such as, and dealing with some of those, including cardiovascular disease and obesity. We are increasingly, as the longer that we're in practice and see patients for years, we are increasingly seeing patients who have been through everything and are still, they may have had good responses, but now are reemerging with active disease. And so we're going to address some of that this evening. Throughout all this, it's going to be clear that we need new mechanisms of action for treating PSA. So I'll now turn over to Mease.
Thank you, Philip, and good evening, everyone. So I'll be talking, giving you some background about elaborate a little bit more about some of these gaps in care in psoriatic arthritis, and introduce the new mode of action of TYK2 inhibition as a potential a new mechanism for psoriatic arthritis. But first, we just wanted to get a sense of your experience with deucravacitinib. So this is the first poll here. So in your practice, what has been your experience to date with deucravacitinib? One is none of my patients have taken deucravacitinib. Two, I've had PSA patients who were taking deucravacitinib that was prescribed by another clinician. Three, I've started deucravacitinib in patients with combined comorbid PSO and PSA. And the fourth is I have started deucravacitinib in patients with PSA based on available clinical trial evidence. So please go ahead and vote. Okay, so it looks like almost half of you have no experience, and the second half are having some exposure, but very few people are prescribing it for a purely PSA, so that's great. So as Philip alluded to, psoriatic arthritis, as you all know, is a very heterogeneous disease with different musculoskeletal manifestation, skin, nail, axial disease, enthesitis, dactylitis, and this makes this condition very heterogeneous, very interesting, but also quite challenging to manage because we have to take into consideration all of these domains and each patient look differently. And these are some lovely pictures of the different manifestations of psoriatic arthritis. And the other aspect that makes the management of psoriatic arthritis more challenging is comorbidities. We know that many of the patients with psoriatic arthritis have comorbidities, and many times these are multimorbidities, so more than just one comorbid condition. We also know that these comorbidities add to the burden of the skin and the joint disease, and that it increases chances of failing treatment, whether this is because of poor efficacy or because of increased side effects. Now, obesity is one of the common comorbidities. 40%, up to 40% of the patients with PSA have obesity, and many more have overweight. So most of the patients have either overweight or obesity, and with obesity there are many related comorbidities such as diabetes, dyslipidemia, hypertension, cardiovascular risk, and many others. Another major and important comorbidity is depression. Up to 20% of the patients have depression, and we also learned that having depression is associated with poor treatment outcomes. And obesity has gained much attention lately because of the emergence of effective medications that can help people lose weight. We don't know exactly how or what is the mechanisms that link obesity and psoriatic arthritis, but one of the hypotheses is that the adipose tissue serves as a sort of an endocrine organ where the adipose tissue becomes dysfunctional with infiltration of pro-inflammatory cells like macrophages and others, and these cells producing pro-inflammatory cytokines such as TNF, IL-6, and others that could potentially increase both the systemic inflammation and also the skin and joints inflammation. But certainly we need to study these links more. However, there is quite a lot of clinical data that show that obesity increases the risk of developing psoriasis and psoriatic arthritis. It can increase the risk of progressing from psoriasis to psoriatic arthritis, and it adds to the burden of disease with people who live with obesity have more pain, have more physical dysfunction, and are also more likely to fail biologic treatment, especially TNF inhibitors. So losing weight is a potential way of reducing this inflammatory burden, making the biologic therapies more effective, and potentially maybe even reducing the progression from psoriasis to psoriatic arthritis. And this is a hot topic in psoriatic arthritis. The availability of these drugs will allow us to study these links. Going back to the treatment of psoriatic arthritis, we talked about the heterogeneity, and one of the things that are emphasized in the guidelines, these are the GRAPPA guidelines, but EULAR guidelines are also emphasizing the importance of evaluating disease activity in the different domains of psoriatic arthritis. So it's not just the peripheral joints. We need to think about the entasis and the axial spine and also the skin. So in order to select the best treatment, we need to understand which domains are active. And once we have this in mind, we could better select therapy because different therapy have different efficacy for different PSA domains. We also adopted the treat-to-target approach, and there are two accepted targets, minimal disease activity, or MDA, and DAPSA, low disease activity. So these are two composite outcome measures that could be used in clinic or in clinical trials, and we attempt to achieve these outcomes. So they can serve as sort of a checklist to evaluate whether patients are actually meeting target, and if they don't meet target, what are the domains that prevent patients from achieving these targets. Now, we'll talk about the fact that many patients are not achieving target, and sometimes this is not because of active inflammation, it's because of other things like pain and physical dysfunction, but without having objective signs of inflammation. And this is where imaging becomes helpful in identifying those patients that continue to experience symptoms but don't have any active disease. So ultrasound is a tool that rheumatologists are using more and more. I use it in my clinic as a way to understand whether patients that continue to experience symptoms, is this because there is some inflammation that I cannot pick up on physical exam, especially in domains like enthesitis, which is kind of hard to pick up inflammation there because patients might have just local pain, but the enthesis is usually not swollen like we expect in the joints. And if we have the ultrasound, we can immediately put the probe and say, oh yeah, this is active enthesitis, this is why the patient have pain, or no, this is not active. This might be because the patient might have fibromyalgia or they have OA or something else. Going back to suboptimal outcomes in psoriatic arthritis, and most of the patients, in fact, don't meet the minimal disease activity state in PSA, despite of the availability of many classes and modes of action. So this is true for clinical trials as well as data from cohorts, real-world data. Only about a third of the patients are able to achieve these targets. So most patients, in fact, don't meet these treatment targets. And these patients who are more resistant to treatment, it might be helpful to try and identify these patients early on in the course of disease because they may need more closer monitoring and more attention than other people. So these are some of the poor prognostic factors that were identified in studies that identify those people that are more likely to have more severe course of their PSA. So some of these are more objective and measures like having more joints, polyarthritis, having elevated markers of inflammation, people that come and already have some damage, so damage predicts future damage. But there are also less objective measures like people with elevated HAC, physical dysfunction, people with comorbidities, going back to the obesity and depression, and then some demographic factors like older age and female sex. Female sex comes again and again as a factor that predicts poor response to treatment, and we still don't understand why this is happening, and this is an area that is being investigated. So in order to facilitate research, we need to agree on the definitions. What is difficult to treat? What is, how can we all use the same words to advance research of these patients that might fail to achieve the optimal target. So this is a recent definition that GRAPPA put together. It was a large project led by Fabian Proft. And GRAPPA defined two conditions. So there is the broader group of patients that are defined as complex to manage psoriatic arthritis, or C2M PSA. So this group is characterized by persistent symptoms despite at least one adequate trial of targeted synthetic or biologic DMARDs. And this really includes not just the people that fail to respond because of immunologically resistant disease, but also people that continue to experience symptoms, maybe because they have severe osteoarthritis, maybe because there are some overlapping conditions like fibromyalgia, access to care, low compliance, other factors that make the management of these patients more complex. Within that, there is a smaller group of patients that is called difficult to treat psoriatic arthritis, or treatment refractory PSA. And these are the truly immunologically resistant patients. So this group is defined as a failure to respond to at least 3 previous treatments, including 2 targeted synthetic or biologic DMARDs, and having persistent symptoms that are perceived to be problematic not just by the physician, but also by the patients, and having an objective evidence of ongoing inflammation. So this could be, for example, a swollen joint, or this could be an imaging evidence like ultrasound that shows enthesitis. So the purpose here is to really focus on those that are really failing treatment because they might have a different profile that is not covered by existing modes of action. So because we have still quite a lot of patients that are failing treatment, it's always good to have a new mode of action, new mechanism of action. And TYK2 is a protein that belongs to the JAK family, and these are intracellular proteins that pair, the TYK2 pair with JAK1 or JAK2, and they transmit the signal of cytokines, including IL-23, IL-12, and type 1 interferon, into the cells, and from there they affect downstream actions of these cytokines like Th1, Th17, and other functions that are relevant to psoriatic arthritis. So a little bit about the pharmacokinetics of this, of deucravacitinib or TYK2 inhibitors. What's unique about this is that these medications bind to the regulatory domain of the protein. And this is in contrast to the JAK inhibitors that bind to the catalytic domain. So the catalytic domain there is shown here in blue, and you can see that all of the catalytic domains are similar across the different JAKs and TYK2, whereas the regulatory domain is unique to each protein. So at least the theoretical advantage here is the specificity to the TYK2 pathway. And this is illustrated here in this graph, where you can see that for the different JAK inhibitors, tofacitinib, ubadcitinib, and baricitinib, they are JAK 1 or 2 inhibition, but there is also some inhibition of JAK2, whereas with the deucravacitinib, there is really very little overlap with the JAKs. And that's, again, theoretically is maybe contributing to the safety of this agent. So to summarize, we have a new mechanism of action here, TYK2 pathway, that mediates the signal from IL-12, IL-23, and type 1 interferon. All of them are key mediators of inflammation, both skin and joints, as well as mediators of damage in psoriatic arthritis. So I will turn it over to Dr. Mease to go over the results of the clinical trial from TYK2 inhibitors. Thank you.
Great, thanks very much, Leahy. Appreciate that. Moving on. So we have data from several sources for deucravacitinib and zasocitinib. Deucra is the sort of lead agent. It's already been approved in psoriasis and underway in terms of approval for psoriatic arthritis. And I'll be going through data in depth about those programs. And Zazo is a similar TYK2 inhibitor, some differences in features of, and so Deucra, besides psoriasis and psoriatic arthritis, so that's an obvious target because of the inhibition of IL-23, IL-12, but also interferon. But the latter also raises the possibility that Deucra could be effective in lupus and possibly Sjogren's. And indeed, one of the things that we have seen is that in the phase 2 program with Deucra in lupus, it was effective and strongly enough effective that it was worthy to go into phase 3. And my understanding is that the enrollment for the phase 3 study has just completed. And so toward the end of next year, we're hoping to know some data about that. In Sjogren's syndrome, we don't have any phase 2 data. They went right on into phase 3. But there too, I can think of many patients in my practice where patients with lupus or Sjogren's would benefit from a new mechanism of action. But tonight we're going to focus on psoriasis and PsA. And then in the Zazo program, besides psoriatic arthritis and psoriasis, they're also pursuing inflammatory bowel disease and vitiligo. Here is the schema for Poetic PsA2. This is a trial in which 13% of the patients had been previously exposed to a TNF inhibitor, and about 2/3 of the patients were on a prior CSD-MARD and continued that as background during the course of the study. A typical phase 3 PsA study in terms of entry requirements, patients had to have active articular disease, and they also had to have elevated hs-CRP. And then there are the primary endpoint of the study was an ACR20 at week 16, and there were a number of key secondary endpoints that are noted there. The patients were randomized to receiving either deucravacitinib 6 milligrams per day, placebo, or apremilast in standard dose of 30 milligrams twice a day. The point of the apremilast arm of the trial was not for a reference arm for efficacy, but was for a reference arm for safety. It was not powered to be a head-to-head trial against apremilast. These are the results that were presented at the EULAR meeting 6 months ago. As you can see, in multiple domains, the drug was effective with statistical separation from placebo, 54% at week 16, and stay tuned because I'm going to show you shortly the week 52 results, and the ACR 50 and 70 responses there. Minimal disease activity criteria that Leahy introduced you to, 5 of 7 items that are a threshold that we're trying to get to, like less than or equal to 1 swollen joint, less than or equal to 1 tender joint, and so on. That was achieved by 25% of patients. And then, as you can see, enthesitis resolution. The SPARC enthesitis resolution was nominally significant, and the dactylitis resolution was nominally significant. And then you see on the right-hand side some patient-reported measures, including the HAQ-DI, the SF-36 PCS, and FACIT fatigue, all of which resulted well. Here's a linear time plot which shows the ACR 20, 50, and 70 results. And as you can see, as we get out to week 52, that there was a slightly ascending curve in all of these, with more responses seen at the week 52 time point by NRI analysis. Number of other important clinical features, including PASI 75 response that was achieved by in 41% at the week 16 time point, and 50 in the mid 50% range at week 52. Minimal disease activity also climbed over time in the high 30% range on average between the two arms. HAC improvement was significant, as was improvement of the physical component score of the SF-36 and fatigue improvement. So all of these are, as you know, important clinical results for our patients. Safety from the PSA-2 trial is noted here. There's really nothing that stood out. This was conducted in a time of COVID, so there were COVID infections. And then other common issues like nasopharyngitis, upper respiratory tract infection, and so on. There really wasn't a signal for serious infection, although we, of course, with any immunomodulatory, we counsel about infection, but we didn't see a serious infection nor opportunistic infection concern. There was really no malignancy signal nor cardiovascular signal. So I think the safety profile of this mechanism, and you'll see this too in the ZAZO data, is relatively benign. One item that's not noted here, just because it wasn't that frequent, but a bit different, was acne. So mild to moderate acne has been noted in a small percentage of patients. And since this has been seen across trials and with different TYK2 inhibitors, we feel that there is something about this where there's an association. When I've spoken to dermatologists who are using the drug about this, they indicate to me that it's a relatively simple and straightforward thing to deal with. This is the PSA-1 trial, and it reported out a little bit later than the number 2 trial. We saw the 16-week data rather than the 52-week data on PSA-2 was reported previously, and now the 16-week data from PSA-1 was reported at EULAR. And at this meeting, I will be presenting the late breaker on this particular 52-week data on this study. The key thing about PSA-1 is that the patients were all naive to biologic treatment, and there was an radiographic component to the study. So we're looking for evidence of inhibition of structural damage progression. There was no reference arm. It was Ducra versus 6 milligrams versus placebo. And then we saw the ongoing extension using all the patients had 6 milligrams. Here are the outcomes. So ACR 20 response was similar to what we saw in the PSA-2 trial, as well as ACR 50 and 70 responses, shown here in bar graph format. And then in terms of other measures, HAC score, PASI 75 achievement in the skin, SF-36 physical component score achievement, MDA at the week 16 time point was 19%, and the facet fatigue here is shown improving, as well as DAS28 CRP. So now we get to 52-week data, and here we see the same kind of phenomenon that we saw in PSA-2, i.e. There was ACR 20, let's look at the primary endpoint, 54% at week 16. And then as the patients continued on that therapy by NRI analysis, over 60% of patients achieved an ACR 20 response. And then you see corresponding ACR 50 and 70 responses. Let's take a look at the radiographic outcomes. So this is a post hoc analysis where all patients' x-rays that were obtained at baseline and at the primary endpoint, and then again at the week 52 endpoint. There was one reading campaign for the week 0 to 16 x-rays, and then a separate reading campaign where the evaluators were blinded to treatment arm in the second period here. And as you can see, there was a separation with a statistical, nominally significant separation in the Ducra group versus placebo, and then that was continued out through week 52, and we see that the original placebo-treated patients had similar attenuation of their X-ray progression. In terms of adverse events, there again, nothing stood out. There we saw some COVID infection, upper respiratory infections. These were enough percentage to get on this table. Acne was again seen. We really didn't see any signal for serious infection, malignancy, or major cardiovascular adverse events. So this is just the timing of the late breaker. You have to get up a little bit early to come to it on Wednesday. I'll be there. And then here is some pooled analysis from these two trials. Pain VAS scale showing improvement, PSED pain, and SF36 bodily pain. So what we're highlighting here are some of the patient-reported measures that are important to patients. Okay, moving on to looking at zasocitinib. We have data from a phase 2b study. There is a phase 3 study that's currently has just kicked off and is underway. In this program, we saw 3 different doses of zasocitinib being investigated versus placebo, and we'll be looking at week 12 data rather than week 16 data. Here are the ACR responses, ACR 20, 50, and 70. And as you can see in the 2 higher doses, 15 milligrams and 30 milligrams once daily, there was really no difference in these particular responses. And on the right, we're seeing minimal disease activity, which was seen similarly in the 15 and 30 milligrams as in about 29% of patients. Here are key dermatologic secondary endpoints, the PASI responses, 75, 90, and 100. And here we do see a differentiation between the 15 and 30 milligram dose, with the higher threshold of PASI 90 or PASI 100 being achieved by more patients in the 30 milligram arm of this medication. And down below, the physician global assessment of clear or almost clear being seen in 20.6 in the 15 milligram and 32.8% of patients in the 30 milligram arm. And the similar story about adverse effects, nothing really to report on. Here, there was a comment about the dermatitis acneiform, so a little bit of acne, but no serious signal about infection, malignancy, or MACE. So one of the things that you're probably aware of is that when the I'll show you the, here's a answer, a QRS thing that you have to answer. Why don't you scan this and answer? Are we ready to move on? Okay, good. Yes, great.
Still moving.
Okay, so one of the items that came out here, 23% of you thought this might be used after a TNF inhibitor. And one of the key things about the safety profile for the psoriasis indication is that there is not a requirement to have to use a TNF inhibitor prior to use of deucravacitinib. So it really didn't have the major safety items that were placed on the JAK inhibitors, such as tofacitinib or upadacitinib, wherein based on the oral surveillance trial, as you know, there is a safety requirement to use those medications after a TNF inhibitor and to advise patients about potential for malignancy and adverse cardiovascular events. We didn't see that in the dermatology approval for deucravacitinib in psoriasis. And here is the data that supported the psoriasis approval. These are the psoriasis 1 and 2 trials, phase 3, where there was a head-to-head comparison with apremilast, which is noted in green, and placebo through week 16. So clearly effective in skin response and separated from both apremilast and placebo. Also through the psoriasis program, because it was started earlier, we have long-term data. This is out through 5 years, and this is showing results of achievement of PASI 75 and sustainment of that through that interval of time. And this is from the psoriasis program where they compiled results, and this is very similar to what we saw in the psoriatic arthritis program. I will comment that there was one very small incidence of zoster here, and again, no cardiovascular signal. So one more question for you, based on what you've just seen. Okay, so I think so the majority of you did get the correct answer there. Okay, and this is just a list of some of the TYK2 inhibitor abstracts that are being presented at this meeting, in addition to the late breaker on Wednesday. And so if you all want to note any of these, to drop by the posters to see them. And a tool, this is an oral, isn't it?
Yep.
Yeah?
Yes.
So a tool was that?
It's tomorrow.
Tomorrow, yes, okay. So that's at 10:15, speaking on the DUCRA data.
So my part of the program, this third part of the program, is going to be much more interactive. I'm going to show you 3 different cases of psoriatic arthritis, and we are going to discuss what would be your choice. I mean, in a way, it's good that nearly half of the audience have never used deucravacitinib. This is a completely new drug for you, and these are hypothetical cases. So it will be good for me to find out what would be your choice in that particular situation. So the title of my talk is this: Constructing Personalized Psoriatic Arthritis Treatment Plans in the TYK2 Era Through the Case-Based Exploration. So these are the therapies that we are currently have available to treat psoriatic arthritis. So this side, of course, is the conventional therapy, but if you add all these small molecules and biologic agents, these are 15 of them. Take my word for it, I counted them. We have got 15 different small molecule and biologic agent therapies. TIC2 will be 16. This oral IL-23, there are presentations in this meeting, which will be 17, then this will be, of course, IL-17A and F nanobody. That's another one. And then this TL1A, this is TNF-like ligand 1A. So, I mean, these are all emerging agents. The question, of course, is how do you decide which one to use when the patient is sitting in front of you already, when there are 15 different therapies? One way of doing that is, of course, to look at the treatment guidelines. This is where the treatment guidelines are important. These are the GRAPPA treatment guidelines. And they tell us that depending upon what is ailing the patient the most, if it is psoriatic arthritis, or is axial disease, or is it enthesitis, or dactylitis, or skin, or nail, etc., then it gives us some guidance as to how or which drugs you would possibly use. This is to help us amongst these 15 different agents. And if you look on the left-hand side here, the peripheral arthritis, all of us, most of us would start this conventional synthetic DMARD, most likely methotrexate. However, methotrexate has very interesting story in that the only study where methotrexate versus placebo was the properly study was done in psoriatic arthritis. That's the MIPA study, MIPA, methotrexate in psoriatic arthritis. This was a study done in Great Britain, and this was criticized because the dose of methotrexate they used was only 15 milligram, and they didn't really go up on that dose. 6-month phase 4 randomized controlled trial, methotrexate versus placebo, and strangely, methotrexate was not statistically significantly better than placebo for any of the major outcomes that they looked at. PSARC, ACR20, DAS28 at 6 months. There was no improvement, strangely enough. Tender joint counts, swollen joint counts, CRP. I shouldn't say no improvement, there was some improvement. It was not statistically significantly different than the improvement in the placebo group. That's what it means. In tender joint count, swollen joint count, all of us use methotrexate all the time for treating psoriatic arthritis. Most of it is based on our experience of using methotrexate in rheumatoid arthritis. Be as it may, SEAM PSA, this is another study. This is, Philip was the first author on this. This was a study which was a randomized study of methotrexate patients with psoriatic arthritis who were methotrexate naive. So they hadn't received any methotrexate, but they were given either methotrexate or etanercept or the combination. And the reason the study was done was to see whether the combination of etanercept and methotrexate is better than etanercept alone. But they did add a third arm, which was methotrexate alone. There was no placebo arm in this study, remember that. And that study showed that methotrexate monotherapy had very good efficacy across joint and skin domains. It was inferior to etanercept for most outcomes. And etanercept plus methotrexate was not superior to etanercept alone. This is also a surprise because in rheumatoid arthritis, we always use a combination. In psoriatic arthritis, this combination is not better than the biologic alone. But the important part was methotrexate monotherapy did show efficacy. This was criticized because there was no placebo group. So whatever that good efficacy that methotrexate did show, was it just a placebo response? We don't know. We all still use methotrexate. So personalized medicine that we always talk about, and we actually do perform some personalized medicine in daily practice. We take into account the patient's preference. We know the data about the skin efficacy and joint efficacy about several different drugs. But we also look at the convenience of the patient, whether they like oral drug, whether they will take infusion, whether they would prefer to have an injection, what were their previous treatment responses, the comorbidities. That actually makes a big difference. This is how we personalize medicine, or we practice personalized medicine. And of course, cost and access becomes very important because, at least in the US, You can prescribe whatever you want. What the patient gets is what the insurance company gives them. So that's cost and access becomes a major issue there as well. So this is all personalized medicine type of situation. So these are all the things that we consider when we are choosing an agent. So here we go. I'm going to present you 3 cases. This is the first case. These are not difficult cases at all. These are straightforward cases. The first case is going to be a new case of psoriatic arthritis. This is Mariana, who is a 41-year-old lady with history of psoriasis and new symptoms of joint pain. She has 14 years history of plaque psoriasis, new onset of joint pain. That's why she's referred by dermatology. She complains of pain and swelling in the small joints of hands and feet. She has a morning stiffness of 45 minutes. It's getting harder to go for morning runs. Back pain is not a major issue. You asked all these questions to her. Experiencing more fatigue, affecting her work. Currently, she is only on this clobetasol propionate. This is just local ointment, topical treatment. She has history of hypothyroidism and depression. She works in a high-stress marketing firm. She exercises 5 days a week. She has a family history of skin cancer and obesity and hypertension. This is family history, not her. And these are some physical findings. Her blood pressure, heart rate is normal. Her BMI is 25, not too bad at all. Skin, erythematous plaques with silver scales on elbows, knees, scalp. This is despite being on this local treatment. And she has these fingers shown there. So there is, from here, it looks like, is it osteoarthritis or is it psoriatic arthritis? So how do you decide in your practice when the DIP joint is involved like this and it looks kind of swollen? Is it psoriatic arthritis or is it osteoarthritis? And of course, you palpate and you see whether this is squishy or not, and et cetera, et cetera. But one of the clues which is given here is the nail involvement. Onycholysis noted on the 4th and 5th fingernails of the left hand, and those are the same joints which are swollen. If the nail was not involved, I would be, and of course she's 41 years old, so chances of this being osteoarthritis are low. There is of course X-ray showing some, you're not really seeing the X-ray that well, but then the central erosions would be osteoarthritis, gullwing type of an erosions on the side would be more like psoriatic arthritis. But one of the clues is that if the nail is involved, and generally those joint pain and swelling, that's really related to psoriatic arthritis. So anyway, take my word for this. She has psoriatic arthritis in those DIP joints. But she also has left wrist and left ankle swelling and dactylitis of the right third toe. So here is a question for you. You have to vote for this now. Scan for the answer. She has not received any drug at all. So would you start methotrexate, conventional synthetic DMARD, or would you start an apremilast, or would you start a JAK inhibitor, or deucravacitinib, or would you straight go to a biologic since she has got 3, 4, 5 joints swollen? Question, the choice number 6 is not available. I'm not sure. Don't do that. Five, 4, 3, 2, 1. All right. So 35% people would choose methotrexate. 35% would choose Deucra. 17%, 18% would choose JAK inhibitor, which in the US is that choice is not available to us. We cannot use JAK inhibitor as the starting therapy unless somebody has failed TNF inhibitor. So, but there are other countries where JAK could be available, or biologic, some people think. What would you do, Lihi?
So going back to the points that we discussed before, I think starting with thinking about which domains are involved.
We want to go back. I don't want this slide. Hang on. Oh, maybe I can go back here. Can we go back? This is the next slide. Okay, yeah. We'll leave this here.
Yeah, so she had skin involvement, right? I think it's also important, we don't know exactly how much skin, if it's 10, 20%, or it's just a few small patches. That's important. And the other important domain is axial disease. She doesn't have back pain, so I think that makes it relatively
Less likely.
less likely.
Yeah.
She doesn't have any of the associate conditions like IBD or uveitis, because these four things could influence the selection of biologics, right? So I think one thing is kind of looking at which domains are involved, but in reality, it's quite easy because at least in Canada, we have to start with conventional DMARD. Nobody is going to pay for a small molecule or a biologic agent. So from my perspective, it would be either methotrexate, sulfasalazine, or leflunomide. And in her case, she's still within the reproductive age. So asking about pregnancy, even at the age of 41, it happens. So if there are no plans, then I would probably go first with the methotrexate.
Yeah.
So my comment is Lihi is from Canada.
Apologies.
So she has to start with methotrexate.
Well,
Whereas in the US.
Oregon belongs to Canada because in Oregon also we have to start with methotrexate. We cannot start with anything else.
Oh, my.
Washington
See,
State is-
Washington is so much superior to Oregon, I tell you. So, I'm intrigued that not more people would have chosen either the biologic option, and I think once Ducra becomes available in PSA, I think it would be, or even to be used now in psoriasis, I think it would be an option. What is true is that we are in the US not allowed to start a standard JAK inhibitor like TOFA or UPA until the patient has already been on a TNF inhibitor. But notice that the ACR guidelines, which are older now and are going to be updated, but they recommend that you start a TNF inhibitor before methotrexate.
Yeah.
And so I think this is an interesting debate. The other thing is I think the team that I work with in the office would look at both the number of swollen joints that she has and the dactylitis as a biomarker of disease severity and say, ooh, this patient we need to be more aggressive about treatment.
Yeah. Thank you. And so what you saw is, again, this is how you individualize treatment. Lihi was saying that you think about what comorbidities they have and then which biologic will go that way and what past medical history she has or how many swollen joints she has. So even though we don't have biomarkers to decide which therapy for which patient, in daily practice, we do individualize treatment based on several of these things, about their comorbidities, about this severity of the disease, et cetera, et cetera. And yes, I mean, there's no right or wrong answer here. Several times our choices are made for by what the insurance company will pay for, at least in the US. All right, now we can go forward. Can we go forward? Yeah. The second case. Now this is Matthew. He's a 54-year-old gentleman. He is naive to biodemars. He has 3 years history of psoriatic arthritis. Go ahead. So he has started methotrexate. So you saw this gentleman 3 months ago as a new patient, and that time you started him on methotrexate. He comes back now for a follow-up. He reports some improvement in pain. So it used to be 6 out of 10, now it is 4 out of 10, so some improvement. Still has swelling in the hand joints. He does have back pain, but it sounds mechanical to you, which is getting better with rest, worse with activity. And the patient says, this is mostly because of my highly required the physical job. He works in the construction. He has had methotrexate that you started, 20 milligram per week, and he has taken it for 12 weeks, so 3 months. And he takes non-steroidals regularly, which is a little bit problematic because he has hypertension, he has got dyslipidemia, he's got obesity. He endorses 10-pack-year history of smoking, still smokes, works in construction, does not exercise, and he has this family history of hypertension and CVA in his mom, and his dad died at the age of 52 with myocardial infarction. On examination, he has his blood pressure is normal, heart rate is normal, his BMI is 33, He does have psoriatic plaques over bilateral elbows and knees. He has got nail pitting. And he does have swollen joints, MCP joints, second, third, PIP joints, 2, 4, and right hand, and PIP in the second and third of the left hand, plus wrists. So that makes it 1, 2, 3, 4, 5, 6, 7 joints, 8 joints. No dactylitis, but he's got left Achilles enthesitis. By the way, these x-rays are terrible. I hope you don't do x-rays like this. This is, God knows what view this is. This is somebody's lying down, I guess. If you order x-rays of your ankles, they better be standing up, AP and lateral. This is somebody lying in, this is from the patient's chart. So I don't know. What x-rays are this? Somebody's lying down like that? Anyway, don't look at the x-rays. Bad x-rays. He definitely has Achilles tendon. So this is a real life case actually. So anyhow, so the question is, what's the next step? So he has failed methotrexate. He has got obesity. He's got all these risk factors. Apremilast, JAK inhibitor, deucravacitinib, a biologic. Please scan and answer. Very good. So, still moving. 57% of the people would start a biologic, 28% would start Deucra, 9% would start a JAK inhibitor, 4% apremilast. Lihi, what would you do here?
Okay, so going back to the patient, this is a patient with polyarticular disease, enthesitis. He has back pain, but we assume that there is no axial involvement. Again, this is the back pain in psoriatic arthritis. We need to be mindful that axial PSA is a little bit different than a non-axial PSA, where back pain might start at an older age, might be less of the typical inflammatory type. So kind of thinking about that and doing the necessary imaging modalities to rule out, because again, if he does have axial involvement, then there are certain biologics that might be less effective in this case. And then I think the other important feature there is the comorbidities, the obesity and the high cardiovascular risk, where I would be concerned about a JAK inhibitor as maybe a first option after failure of the conventional DMARD.
Can you do that in Canada? You can give.
We can give JAK inhibitors
before TNF?
We can.
I see.
But in this particular case, I would not think that would be the preferred option. And then we are left with the other option, and I think the biologics and deucravacitinib would be potential options in this particular patient, and then it goes back to patient preferences, injectable or an oral agent.
Excellent. Yeah. Philip?
I would completely agree.
Thank you.
And I would also add a GLP-1 GIP receptor agonist.
Yeah, that's a great point. So what Philip is talking about is we are now adding weight loss type of drugs in patients with psoriatic arthritis because there is some evidence that they will help in psoriatic arthritis. And he has a BMI, this person, of 33. So, yeah, I would agree. And again, there is no right or wrong answer here. This is all discussion because these are all real life situations that we will face. Can I have a next slide? Yeah, so this is the last patient that we are going to discuss. This is Phoebe. She's a 36-year-old lady with uncontrolled psoriatic arthritis. Now, this is the extreme. The first patient was completely naive. Second patient was methotrexate, inadequate responder. This lady is biologic, inadequate responder. This is the difficult to treat patient that it will fit that description. 10 years history of psoriatic arthritis, returning for a follow-up visit with concerns about ongoing psoriatic arthritis symptoms, persistent stiffness and pain in hands, wrists, knees, and ankles. Psoriatic arthritis is impacting her mood and ability to take care of her young children. 3 and 6 years old. She already has depression as one of her past medical history, as you see there. She has tried she is on risankizumab. She is on meloxicam. Those are her current medication. Before, she has tried methotrexate and adalimumab and secukinumab. So one anti-TNF, one IL-17A inhibitor, and methotrexate. I'm currently on IL-23, P19 IL-23 inhibitor. She has history of psoriasis, obesity, and depression. She never smoked, occasional alcohol, no illicit substances, stay home mom for these 3 and 6-year-old kids. She does not feel able to exercise regularly due to stress and pain. Her mom had obesity and psoriasis and psoriatic arthritis, and dad had basal cell carcinoma. Here are some pictures. Vitals are again normal. Her BMI is 37. She has plaques on elbows and trunks and scalp, 5% body surface area. She has nail pitting. She has no onycholysis. She has swollen and tender joints, 6 tender joint, 3 swollen joints, Leeds enthesitis index of 3, reduced grip strength, no dactylitis, no axial or SI joint tenderness. And she's tearful during part of the visit. And what is shown there is her back on these, that is the psoriasis, and there is that index finger with an erosion. All right. So what would you do? What next therapy would you consider for Phoebe, who is currently on meloxicam and what is she on? Risankizumab. Thank you. And she has failed TNF inhibitor and IL-17 inhibitor. Switch to a biologic that she hasn't tried. Combine biologics. Add a JAK inhibitor to risankizumab. Add deucravacitinib. All right, so 45% of people do think add deucravacitinib, even though Philip has not shown you anything, but you haven't seen anything about adding deucravacitinib. This is faith-based medicine. Interesting. All right, add JAK inhibitor, a combination of biologics, or switch to a biologic she hasn't tried. Lihi, what would you do?
I would first inquire about compliance. Ask gently, are you actually remembering to take the medication? I think that's the first kind of thing to make sure. And then I think the other piece of information that is important is the response to the previous medication. So sometimes if it is a secondary failure, there was excellent response, then maybe that is something to consider, potentially a class that worked in the past and just lost efficacy over time, or just primary failure of a biologic. And I think these could potentially add to some of the considerations. And if these are all kind of the options there, so there is an option of moving to another class. Yes, this is more the conventional way, or combination therapy, which is, it seems like most of the audience here would prefer. This is, of course, off-label because, and it might be also quite hard to fund because, get approval for both a biologic and a targeted synthetic therapy. And Atul, I know you're going to show some data from our site about combination therapy. So we've been using the deucravacitinib with an IL-23 or an IL-17 inhibitor, and this could be an option in a patient who seem to be meeting criteria for difficult to treat, already have some erosions, active skin, active joints, and this might be another option for this particular patient after discussing the fact that this is off-label and,
Philip?
So I think this response is very interesting in that there has been discussion going on at multiple levels about the potential that a TYK2 inhibitor could be a particularly good drug to be used as dual therapy with another biologic or with a biologic agent. And I'm wondering how many of the audience really understood add versus instead of risankizumab. But I think it's a really interesting possibility. One issue you might think about is, well, she's already on an IL-23 inhibitor. Do you go to something that's a little bit more different or not? But given the safety profile of deucravacitinib and the fact that it has broader reach than just IL-23, including alpha interferon, I think it's a very interesting potential choice. The way we would do it in our center we would ask her dermatologist to prescribe one of the drugs, and then we would prescribe the other one. And that's one way in which we've gotten it through insurance, by having the two different physicians from different disciplines doing it. And I know in your center, that's how it's done, because Cheryl, there's a dermatologist that they work closely with that is willing to do this kind of experimentation. I don't think it would be a risky thing to do at all. Again, because of the fact that we're just not seeing, either with risankizumab or with Ducra, a meaningful infection signal. So I think what this audience is doing is looking ahead to the future when dual therapy is going to be more common.
Yeah, I would agree. There is one feature that we added. She has depression, and she was tearful and all these kind of things. So that also you would then consider, because there are certain drugs that we use in psoriatic arthritis which have warnings for depression and suicidality and all this kind of stuff. And that's not uncommon in psoriatic arthritis patients. So that clue also was there, that we have to make that or take that into account when we are deciding what drug we would use. But I completely agree that the safety profile of Ducra is such that we always worry when we're combining biologics or combining these small molecule and biologic, worried about safety. But the safety seems to be pretty good. So,
by the way, she's ripe for having a heart-to-heart emotional conversation about depression. The telltale is that she's crying in the exam room with you, and it's an opening to have that kind of conversation.
Yeah. So this patient actually did participate originally in the psoriasis study of deucravacitinib. It got approved for psoriasis in 2022, 3 years ago. And this is 48 weeks later. This is that her skin cleared. And interestingly, 2 years after the deucravacitinib, her erosion, interestingly, which I showed you earlier, that also got better to an extent. So this is the combination therapy that Lihi was talking about. This actually was presented last year, but also today there was a poster on this. This is a combination therapy in psoriatic arthritis, the Toronto experience. So they have a very large database of cases of patients with psoriasis and psoriatic arthritis. And these were patients who had failed multiple biologic or targeted synthetic DMARDs, and they had active skin, active joints. And the question came as to what to do. And then a dermatologist, exactly as Philip was saying, dermatologist was prescribing one biologic, and then the rheumatologist in Toronto could prescribe a second drug. And what is shown on the right-hand side is the drug combinations of that they tried. So IL-23 plus TYK2, similar to what Phoebe's case was, they had 10 cases. IL-23 plus JAK in 2 people, TNF inhibitors with TYK2 in 1 person. This is all, of course, this is anecdotal example, but this is example from a center of excellence like Toronto. And what is shown in the graphs is the tender joint count dropped, the swollen joint count dropped, the disease activity dropped, and safety is shown at the left side bottom there, which they didn't have much of a problem. Where is my pointer? Okay, here it is. So this is the safety. So there was just one upper respiratory infection, one stomatitis, two upper respiratory, well, folliculitis, etc., etc. So you didn't have any major hospital admissions and sepsis and any of that. But then, of course, that's because TIC2 is a pretty safe thing to add. So you guys guessed right. I mean, the safety profile is so good, it is going to be problematic to get it approved through the insurance or do it this way that you get your dermatologist to prescribe a drug and then you prescribe another drug. This was mentioned already, TYK2 inhibitors do not have the serious safety concerns associated with the JAK inhibitor class. On the top, what you're seeing are the boxed warnings applied to the JAK inhibitors. None of them apply to TYK2 inhibitor. The safety profile is very favorable based on this available evidence. There are no boxed warnings have been applied. And so these were the three patients that we looked at. Mariana, who was new onset psoriatic arthritis, naive to any treatment, Matthew, who was methotrexate inadequate responder, and Phoebe, who was biologic inadequate responder. And the questions on the right, I'm not going to ask you to vote on, but this is something that we just need to mull in our own mind. We need to think about this when we are seeing these patients. How are we going to monitor? I mean, I would probably see these patients after changing their biologic or adding a TYK2 onto that in 3 months' time or 4 months' time latest. Engage them. Of course, these are all shared decision making. We always have we discuss with them what risks are and what benefits are. And we collaborate with other members of the healthcare team like dermatology and primary care, etc., as shown here. This is a team sport. This is, it takes a village to treat a patient with psoriatic disease. Of course, rheumatology and dermatology are on the top, but then more and more we are seeing cardiologists and endocrinologists in getting involved for obesity control, sometimes gastroenterology if they've got IBD. Primary care primary care needs to be involved as well. And then there is ophthalmology if they've got uveitis or mental health problem is there, then we have to involve the behavioral health team as well. So here are the key takeaway messages. A need remains for safe and effective and convenient oral treatment. Deucravacitinib is that oral treatment there. TYK2 inhibitor is a key mediator in cytokine signaling. And it's the first-in-class oral allosteric TYK2 inhibitor approved by the FDA in 2022 for psoriasis, currently under review for psoriatic arthritis. And there is another one in the wings, zasocitinib, which is also a TYK2 inhibitor, which has shown promise. So that will also go in front of the FDA at some stage. And a personalized team-based approach, and that's what we were talking about in all these three cases, how we do personalized approach based on their side effect or their past medical history, what drugs they have tried, what their personal choices would be. And that is the way we should be treating psoriatic arthritis patients. So thank you for listening. I want you to scan this code again to answer the final follow-up poll and to ask faculty your questions. What's the durability of response to deucravacitinib and onset of action in psoriatic arthritis compared to psoriasis? Do you want to answer that?
Oh, we don't have long-term data. We have the 52 weeks, right? So we know that it's durable at least for a year. We will learn more with long-term extension. And I guess it does show a response within 16 weeks. So that's kind of sort of the conventional time point that we expect, right? So about 3 months.
Both the studies, the PSA1 and PSA2, have completed 52 weeks. So at least in psoriatic arthritis, data only goes up to that, but I completely agree that we'll have to wait and see. And Philip actually showed that graph as to when it separates from placebo. It's quite early, actually. Within 8 weeks, it starts separating. But by 16 weeks, it definitely becomes statistically significantly different. Is there any evidence of efficacy with TYK2 inhibitors in difficult domains like axial disease? And the answer is no. Enthesitis, The answer is yes. So they had two things. They had the um, the spark enthesitis score and also the Leeds enthesitis score. The Leeds enthesitis score was not really statistically significant. Leeds has only 6 sites. The spark enthesitis score was nominally significant.
Yeah. And we have to keep in mind that, of course, clinical enthesitis is not sonographic enthesitis, and it
Oh yeah, good point.
may not actually reflect inflammation. It may be a measure of pain, but this is how we measure enthesitis in clinical trials.
How should clinicians manage patients switching from biologics or JAK inhibitors to deucravacitinib? So how do you answer this question? How should we manage patients switching from biologic or JAK inhibitors to deucra?
So I'm not sure that I would manage them differently than any other switch. I would just monitor disease activity and discuss the potential adverse effects, but I don't think there is any particular or disease-specific monitoring that.
I would think this would be actually easier because for JAK inhibitors, I do check their CBC and CMP every 3 months, just like methotrexate. That's what I do with JAKs. Here, you don't need to monitor CBC or CMP. Yeah. So this is, in fact, will be an easier, if they switch to deucra from JAK inhibition, this is going to be easier to manage. What are the laboratory monitoring requirements in practice? And the answer is none. No laboratory monitoring requirement. Is there exploration of deucra in axial spondyloarthritis or lupus? So not in axial spondyloarthritis, but lupus, yes. And there was, Philip actually mentioned about the lupus phase 2 study was completed. Phase 3 study is going on.
Yeah.
What do you think the role of TYK2 inhibitors will be in the treatment regimen for patients with C2M and D2T PSA?
I think we talked about it.
Yeah.
I think,
so Phoebe was, so we actually, that's why we put that case, Phoebe. That was difficult to treat.
Yeah, difficult to treat. She clearly met criteria for difficult to treat.
She had failed one TNF inhibitor, one IL-17 inhibitor. So.
And had clear evidence of active disease as opposed to complex to manage, which may be just because of other reasons. I think deucra would fit in both cases. In the case of difficult to treat, I think combination would be something that would be considered.
I would agree with that. Let's see. Do you think TYK2 inhibitors will replace JAK inhibitors? I don't think so. Or is there a role for JAK inhibitors still once these agents are approved? I would think that there is definitely a role for JAK inhibitors even when TYK2 inhibitor is approved, because as we said that the more choices we have, the better. There would be some patients where JAK inhibitors could be useful. There was one study which was a head-to-head study published. Ian McInnes was the first author in New England Journal of Medicine. This was Rinvoq, or I should say
Select PSA.
Select
PSA.
Select PSA. Upadacitinib versus adalimumab.
Yeah.
And the double dose upadacitinib 30 milligram, which is not approved for the treatment, but at least in the studies that did upadacitinib 30 milligram versus that was superior to adalimumab, and I was pretty impressed with that study.
And I think it's also the fact that the JAK inhibitors, they block other cytokines that are not blocked by deucravacitinib.
Right.
Yeah. So these are they have different profiles, and yes, the safety issue is a concern, but I think it goes back to the personalized therapy in a maybe young female who has very low cardiovascular risk. That may be less of a concern. Yes, we need to discuss it, which makes it difficult, but ultimately the absolute risk of developing a heart attack in a 20-year-old female with no cardiovascular risk is very similar to that of an adalimumab, which is close to 0.
Yeah. The next question is also, we kind of answered, or when we discussed our third case, how does deucra fit into the treatment algorithm if a biologic loses efficacy, and what if the comorbidities limit options, like heart disease or diabetes or etc. And this is similar to, this is the situation like Phoebe, the third case, where the biologics, she had tried 3 different biologics and they had lost efficacy. And Ducra would be a good idea to add into the regimen, like Toronto's experience, and see whether that works. How will we get that? That will be, again, that's not on the label, but it is worth trying that way. The next one is also kind of similar. In what patients should Ducra be prioritized, bio-naive or skin-dominant? I personally would think that it could be a starter therapy, if available, because in my mind, Ducra has much stronger data compared to methotrexate. We use methotrexate all the time. We are forced to use methotrexate, et cetera, but the quality of data that Ducra has when compared to placebo is way superior, and I would like to use this as my first line of treatment. And there is no CBC, there is no CMP to be done every 3 months. It has got safety, no liver toxicity. It would be great to use it in bio-naive population and as the startup treatment. I would, but it's going to be, the issue is going to be insurance and all. Yeah, right. Skin dominant?
I think it also depends on, again, some people would prefer an injection every 2 months rather than taking a medication on a daily basis. So it all goes back to discussing it with the patient. I believe our role is to kind of provide the information. Sometimes there is clear agent that would be a priority, but many times there are several options, and we need to help patient navigate the information that we have and trying to make an informed decision.
Wonderful. We've got the last question. What is the expected timeline for clinical improvement with joint, skin, and PROs? Weeks or months? And the answer is weeks. But then I bring you back to, well, there are a few posters and oral presentations, and you need to look at that graph when they show, and then there you see when is the separation. When is the separation for joints? When is the separation between placebo and the active treatment? And then you would really, and Philip showed that some of those in his presentation. I have a presentation tomorrow as well in the morning, and Lihi has a presentation, oral presentation on Ducra as well. But the answer is it's weeks, not months. The joint and skin and patient-reported outcomes, I'll be speaking on that tomorrow, but that is in weeks, not in months. So it is a pretty quick action. Okay, well, thank you all for coming and attending this symposium, and hope you learned something new and enjoyed it. Thank you for joining us. So please scan this QR code once more or visit this peerview.com to claim your credit and access the activity materials, and stay tuned for online activity based on this event. Thank you.